much, and I would also like to welcome you all to this webinar about addressing the endocrine changes of menopause through MHT. And I'm very happy to introduce Professor Sanjay Kalra, endocrinologist at Bharti Hospital, Karnal, India. So please, Professor Kalra.
Thank you, Dr. Angelica, and warm greetings to everybody who's gathered with us from across the world. We'll be speaking today about menopause. We'll also talk about menopausal hormone therapy, but let's do it through an endocrinologist lens. In endocrinology, we study hormones. We study health due to hormones, and we also talk about minimizing disease or dysfunction due to hormones. And menopause is a hormonal disease. So let's talk today about how we in endocrinology view menopause, how we view it as an opportunity to achieve better health for all women, and how we view this window of opportunity as something that can help us improve or ensure healthy aging. Now, when we use the word aging, reproductive aging is one aspect of that. And aging doesn't begin at one particular age. Or
sorry, Dr. Kalra, we cannot see your slides. If you can please share them. Sorry for the interruption.
Yeah, are they visible now?
Yes, from beginning, please.
Are they visible now?
Yes, thank you so much.
Thank you. So I apologize for that. So like I said, in endocrinology, we are used to this kind of, dysfunction, a few hormones going up, a few hormones coming down, maybe some slides not getting visible initially, but then these are minor hiccups. And if you have an endocrinologist's mind, an endocrinologist's attitude towards healthy aging, then these are small issues which can be taken care of very easily. So now that we have the slides in front of us, we'll talk about the metabolic milieu and about aging. Now, aging doesn't begin at any particular threshold. Aging is related to chronology or to calendar years, but there is much more to aging. And actually, when you see a woman, a lady, you will find that reproductive aging begins right from puberty. There are so many eggs or oocytes that are present in every woman, in every girl, but out of those, just about 450 finally get released. And how does this happen? It happens every month because of an interplay between hormones from the hypothalamus, the pituitary, and the ovaries. As women reach the end of the 5th decade, or maybe around 47, 50, 51 years, there are sudden changes in ovarian function. This happens due to hypothalamic feedback mechanisms. In India, the average age of menopause is 47. In Europe, it is about 51. It would be nice to have questions and comments from all of you in the chat box. What is the average age of menopause in your country? When we look at women's endocrinology, it's very interesting for a student of endocrinology. In general, the endocrine system is based upon negative feedback mechanisms. But there are at least 3 examples of positive feedback mechanisms. All these positive feedback mechanisms come from female reproductive endocrinology. Let's look at the examples. First of all, LH surge. LH surge, which occurs at the time of ovulation. Second, oxytocin, leading to uterine contractions, leading to more oxytocin, leading to more uterine contractions, leading to delivery of a child. This is during labor. Third example, let me ask everybody to guess. So we created an ovum, we had ovulation with the positive feedback. The baby got delivered with positive feedback. What comes next? So that's again a question and a comment for everybody, a question and an opportunity for everybody. What is the third example of positive feedback that you see in female endocrinology. While all this is going on, you see that gradually ovarian reserve declines. And this begins declining at around age 15 to 18 after puberty, and it goes down until menopause. This decline in ovarian reserve, decline in fertility, is associated with a decline in estrogen. And what happens at menopause is, along with the decline in estrogen, you do have a sudden rise in FSH. All this is physiological. But because of this physiological change, there might be symptoms and there might be signs in some women. What are these symptoms and signs and laboratory abnormalities? What is the syndrome of menopause? Let's understand it through this M mnemonic. M is for mood and cognitive dysfunction. M is also for motor or vasomotor symptoms. M is for micturition and genital symptoms or signs, genitourinary. Another M would be musculoskeletal. Yet another M is metabolic, cardiovasculometabolic, and also glucometabolic. Glucometabolic we can translate as diabetes or dysglycemia. And the last M we would like to talk about, but not the least, is malignancy. Let me repeat this list again. M for menopause can be associated with disturbance or dysfunction in mood and cognition, vasomotor health, micturition and genital health, musculoskeletal integrity, metabolic function, and malignancy. Many of these are associated directly with estropenia, with low estrogen levels. Some of them respond directly to menopause hormonal therapy. So when we view, as endocrinologists, when we view menopause through a hormonal lens or through an endocrine lens, this is what we see. We do not see just the ovary. We do not even see just the ovary and the pituitary gland or the hypothalamus. We see the entire lady in front of us. And we see each and every organ system of hers. And as endocrinologists, as gynecologists, as other healthcare professionals, it is our responsibility to take care of this beautiful lady in front of us. I am reminded of a quote by Rabindranath Tagore. Rabindranath Tagore is the national poet of India. He was the first non-European to win a Nobel Prize in Literature more than 100 years ago. He has penned the national anthem of India as well as Bangladesh. What he said was, the beauty of a flower, the beauty of a flower is lost if you pick all its petals apart. Let us not pick these petals apart, all these petals, these M's that we see in front of us. Let us keep them together so that we can ensure and maintain the beauty of the woman who is living through menopause. Of course, when you study a flower, you do study the petals, the sepals, the pollen, everything separately, but you keep it all together. That is what we will try to do over the next 1 hour or so. And in pursuit of this, in pursuit of keeping that beautiful flower whole and hearty, we speak of holistic care of menopause. Now, I know that our chairperson today, Dr. Angelica, is a very renowned authority, a very respected voice in this particular field of menopause management, and we would like her to share her views upon this particular slide later on. But when you look at the lady living with menopause from a holistic manner, this is what you have to consider. Look at the etiology from a holistic perspective. Think not only of biomedical issues, but also of psychological contribution and social contribution to health. Think about the chronic disease care model. The patient may have come to you with an acute symptom, which can be a hot flash, or which can be a maybe genitourinary atrophy, genital atrophy. But you have to treat her from a chronic care perspective. The patient may have approached a gynecologist, a urologist, an endocrinologist, or a family physician, but none of us is strong enough to treat her alone. We do need a multidisciplinary approach. And if we are dealing with a lady from a different culture, then we have to be sensitive to her needs. You will find there is ample data across the world to show that Western women have different symptomatology in menopause. Eastern women have different. In some cultures, menopause is a badge of honor because a lady who suddenly, who was earlier considered subservient, suddenly gets a higher status in society and becomes healthier from a psychosocial point of view. Not only are these etiologies and etiologic factors to be considered in a holistic manner, we also have to look at our targets from a holistic point of view. Will we look at estrogen levels? Will we just look at genitourinary health? Or will we also look at the bones? If we are looking at the bones, why do we not look at the joints and muscles alongside? And are we finally treating an endpoint of bone health and muscle health? Or are we actually trying to reduce the prevalence of the geriatric giants like fragility and fall and fracture? We should have that in mind, and we should have an open mind towards all this. And if we are managing menopause, then will we not manage the comorbid medical and surgical conditions that the lady presents to us with? The answer is yes. If we are managing menopause, will we do it only with menopause hormone therapy, or is it within our ambit to provide holistic therapy, including non-pharmacological treatment? If we are providing non-pharmacological treatment, should we not offer support, holistic support to the patient and her family, and perhaps ourselves as well? So we should focus on stress management, coping skills training. If the lady is not able to cope with the demands of living with menopause, with the demands and challenges of living with menopause, we should help her learn how to cope. We can offer therapeutic patient education. Patient education will be therapeutic in itself. It will be a therapy in itself. We call it menopause therapy by the ear. Now, many times when I ask my students in South Asia, what is menopause therapy by the ear? They scratch their heads, they scratch their hair, and then they come up with the sir, maybe estrogen ear drops. Now, that is not what we mean by menopause therapy by the ear. What it means is, and again, I will request Dr. Angelica to speak more about this, give your ears to the lady. Listen to her with both ears open. Listen to her in a way that you would want to be listened to yourself. And when you speak with the lady, speak with her in such a way, speak with empathy, with understanding, speak with her in such a way that you would want to be spoken to yourself. If we can practice menopause therapy by the ear, we will certainly be able to minimize compassion fatigue and burnout amongst the women with menopause, amongst their family members and caregivers, and also amongst ourselves. And to do all this holistic management, we have to have a holistic delivery of care. So be person-centered, be woman-centered, and whatever decision you are making, inform the lady and share the decision with her. Make her feel empowered, make her feel in charge of her life, and try to minimize the discomfort of change. With all this background, let's move on to brass tacks, and let's see actually the endocrine aspects of menopause. Now, most often, women will come in with vasomotor symptoms. As a gynecologist, as a women's health provider, you may be excused if you feel that vasomotor symptoms are linked only to estropenia. But the point is actually that vasomotor symptoms are a marker not only of estropenia, but also of insulin resistance. Vasomotor symptoms are a marker of dysglycemia, of a pre-diabetic state. Women with a reproductive lifespan of less than 30 years have a higher risk of developing diabetes. So if you have somebody with premature ovarian insufficiency, or somebody with early menopause, the risk of pre-diabetes and diabetes is going to go up. And especially if you have somebody with the hot flash, what this suggests is that there is a lower estrogen concentration, a sudden reduction in estrogen, and it shows that there is going to be a greater risk of development of type 2 diabetes. So this is actually a pre-diabetic state, hot flash, which you can utilize to initiate preventive strategies for diabetes. This is not only true for women and menopause, it is also true for men and so-called andropause. Men who have low testosterone are at higher risk of developing diabetes and metabolic syndrome. So this way, amongst both genders, the thought process and the physiology or pathophysiology is the same. If we can catch these people in the pre-diabetic state, and how will we catch them? Just by taking a history of hot flash, we might be able to initiate interventions which will reduce the risk of diabetes later on. In men also, if you add testosterone to lifestyle modification, in hypogonadal men, you will actually be able to reduce the risk of type 2 diabetes. And that is true in women as well. If you are able to give to a hypogonadal woman, that is a menopausal lady, if you are able to give menopause hormone therapy, you can reduce the risk of type 2 diabetes statistically significantly. Look at all these major trials done across the globe. There is a 20 to 35% reduction in the risk of diabetes. It is statistically significant. So we speak so much about diabetes and about prevention of diabetes, remission of diabetes, and we speak about diet and exercise and stress management, all the things that are difficult to do for a normal human being. But we do not speak adequately about the role of modulating and modifying menopause through MHT as a type 2 diabetes prevention regimen. Diabetes does not occur in isolation. So we have shown data that menopause hormone therapy reduces insulin resistance. It reduces the onset of type 2 diabetes. But all this is part of a greater syndrome known as metabolic syndrome. How do I remember metabolic syndrome? D for dysglycemia, H for hypertension, O for obesity, L for fatty liver, and L for dyslipidemia. When you prescribe hormone replacement therapy or MHT, you will find that all these metabolic parameters are improved. And the underlying factor is a reduction in insulin resistance, calculated by HOMA-IR, or an increase in insulin sensitivity. Irrespective of whether your patient has type 2 diabetes or not, whether your patient has pre-diabetes or not, or other aspects of metabolic syndrome, MHT is safe for use. Modern MHT is very safe. However, MHT is not recommended per se for the prevention of diabetes as of now. But when you are prescribing MHT to a patient for other indications, maybe for vasomotor symptoms, you can counsel her that this is going to improve overall metabolic well-being. In perimenopausal women or recently postmenopausal women with type 2 diabetes and low CV risk, you can use oral estrogens. In obese women with type 2 diabetes or in those with moderate CV risk, we may wish to use transdermal 17-beta estradiol. Irrespective of what estrogen we use, and of course we would want to use a lower dose of estrogen in women who have been menopausal for at least 2 years or more, we would want to use a progestrogen, a natural progestrogen with minimal effects on glucose metabolism. So the best possible progestrogen should be used. We've spoken of diabetes, and we did say that diabetes is just part of a larger syndrome known as metabolic syndrome. Metabolic syndrome does increase suddenly and steeply after menopause. The risk doubles actually. The moment a woman enters menopause, her risk of developing metabolic syndrome goes up. We spoke of many things, dysglycemia, hypertension, obesity, dyslipidemia, but the underlying factor is insulin resistance. We did mention one marker of pre-diabetes or increased risk of diabetes onset, and that was hot flash or vasomotor symptom. Another marker of metabolic syndrome is premature ovarian insufficiency. Women with premature ovarian insufficiency have a higher risk of metabolic syndrome. Metabolic syndrome is quite high, not only in the West, but also in Africa and in India. This is an original study that I was part of. It was conducted in Lagos, in Nigeria, in West Africa. And here we found a prevalence of 69% of metabolic syndrome. The menopausal symptoms, however, were the same in women with metabolic syndrome and those without. One of the reasons why metabolic syndrome increases after menopause is because of estrogen deficiency. Now, the term that we use in endocrinology is Barrow phenotype. B-A-R-O, Barrow phenotype. The English word phenotype means the sum of all external attributes. Barrow phenotype means the fat distribution of a particular individual. What is the body mass index? What is the abdominal circumference? How much of visceral adiposity is there? How much of subcutaneous fat is there? This is Barrow phenotype. Barrow phenotype is strongly influenced by estrogen. If you have high levels of estrogen, you will have more of peripheral fat, relatively healthier fat, less of central fat, less of unhealthy fat. But the moment we get estropenia, then there is predominant abdominal fat accumulation, worsening of lipid profile, and insidious onset of cardiovascular disease. We spoke of worsening of lipid profile. If you actually give estrogen to a patient in menopause, you can increase HDL cholesterol. It is very difficult in metabolic practice to increase HDL, the healthy cholesterol, high density lipoprotein cholesterol. But one way in which it can be done is by giving MHT. Not to say that estrogen, this is not to say that estrogen will be a primary treatment for low HDL. The first treatment would be lifestyle modification, but still we should be aware of this. When you compare estrogens with tibolone, another type of menopausal therapy, we see the advantage of estrogen because tibolone reduces HDL or reduces the good quality or the friendly cholesterol. Women with very high levels of triglyceride can be treated safely with transdermal estrogen. And if you have a lady with dyslipidemia or obesity, we already mentioned, or metabolic syndrome, again we mentioned, or moderate risk of CVD, we would prefer a safe progesterone like dydrogesterone or micronized progesterone. So though we do not suggest that MHT is a primary treatment for all these, we should be aware of all the benefits. And if there is an indication for MHT, symptoms of estropenia, for example, we should not hesitate from prescribing MHT to all these women with metabolic dysfunction. If you're practicing in gynecology, again, you should be aware of the benefits of MHT to your patient, and you should be able to counsel your patients confidently. We've spoken of diabetes, we've spoken of metabolic syndrome. Now let's speak about cardioprotection specifically. Why is it that we want to manage diabetes? Why is it that we want to minimize metabolic syndrome? The reason is we want cardiovascular health. And estrogen actually helps improve cardiovascular health. It is lipid friendly. It has antiplatelet activity. It protects the endothelium of the blood vessels, and it is an antioxidant. When you prescribe MHT, you do not have to worry about an increased risk of cerebrovascular accidents. In fact, there is something known as the time hypothesis, the timing hypothesis. Earlier, there was a worry about increased CV events with the older hormone replacement therapy. But what we see is that if you prescribe estrogen or estrogen and progesterone nearer to the onset of menopause, in people with recent onset menopause, this is actually protective against coronary heart disease. If you prescribe estrogen or estrogen and progesterone 10 years after menopause, it will be a neutral effect. There will be no benefit, but there will be no disadvantage as well. So if you have this lady coming to you within 10 years of menopause, you should feel comfortable in prescribing hormone therapy. And if your patient has come to you within the first 4 years of menopause, you can very confidently tell your patient that this is something which may help you. In younger women, actually, menopause hormone therapy has been shown to reduce the risk of coronary heart disease events. So if you have a lady, like I said, within 10 years of menopause or less than 60 years of age, feel confident that you are helping your patient improve her symptoms, improve her quality of life, and also improve her heart health. It's not only about heart health as well. It is also about all-cause mortality. So if you start MHT within 10 years of menopause, all-cause mortality does go down. Not only coronary heart disease, but also overall mortality will come down. And see, it is statistically significant because when you see the top row, you find that the upper end of the confidence interval is 0.95. So this means there is statistical significance. If you start after 10 years of menopause, mortality will remain the same, heart disease will remain the same, stroke will also remain the same, but there may be an increased risk of venous thromboembolism. So that is something you have to be careful of. In the beginning, I said that we view, in endocrinology, we view menopause as a window of opportunity. So what is this window of opportunity for me? First of all, if the lady comes and complains of vasomotor symptoms, I will view them as osteopenia, but I will also view this as a biomarker of cerebrovascular disease, cardiovascular disease, sorry. So for me, vasomotor symptoms are like an anginal equivalent. If my patient has come in within 10 years of menopause or below the age of 60, I will not only consider vasomotor symptoms as an anginal equivalent, I will also want to treat them. Why will I want to treat? Number one, to stop the vasomotor symptoms, to improve quality of life. Number two, to improve heart health. So such patients for me will be an anginal equivalent. There will be a window of opportunity, and I will utilize this window of opportunity to give symptomatic relief and metabolic benefit. Many of you must be aware, those of you who do not work in diabetes, that now when we speak of diabetes care, we speak of cardiovascular outcome trials. Cardiovascular outcome trials. And we try to choose drugs which not only offer glucose control, but also offer cardiovascular safety and cardiovascular benefit. One such drug which offers symptomatic relief, glucose improvement, cardiovascular safety, and cardiovascular benefit is menopause hormone therapy, provided it is given to the right patient. And here the cohort that we are speaking about is women with vasomotor symptoms. So this is it's a strong statement, but it just helps us share that if we view our patients through a metabolic lens, an endocrine and metabolic lens, we can help our patient in a holistic manner. Don't think only about the ovaries, only about the skin. Think about the entire person in front of you, that beautiful flower. And when you're thinking of this entire person in front of you, how can you miss the musculoskeletal system? While peak bone density is achieved during adulthood, early adulthood, and peak bone mass accrual occurs during puberty, it is in menopause that certainly bone health goes down. Bone mineral density reduces in menopause, And the women are at a higher risk of osteopenia and osteoporosis. If a lady has osteoporosis, she will have a higher risk of fracture. And fractures are not good for health, especially fractures of the hip are associated with more morbidity and mortality. In menopause, what happens is that there is less bone formation and increased bone loss. So we end up with weak bones. And it is this complication of menopause, which actually puts the maximum burden upon the healthcare system. Vasomotor symptoms, they are more associated with morbidity, but osteoporotic fractures are associated with morbidity and mortality. So we need to fix these up. How do we ensure that we are able to prevent osteoporosis and prevent fractures? You screen all women, you do a DEXA. If DEXA is not available, you can use FRAX tool. Most countries have a FRAX tool for their own countries, validated tools. The original tool comes from Sheffield in the United Kingdom. So just Google FRAX, F-R-A-X, and you will be able to find the fracture risk of your patient. Very simple algorithm. If osteoporosis has been diagnosed, then we have to treat. Now, there are many drugs available to treat osteoporosis. Many, many drugs now. Our armamentarium has increased a lot in the past 1 or 2 decades. But do not forget that giving menopause hormone therapy actually improves bone mass. And this is a dose-dependent effect. So if you give good doses of estrogen in a safe manner, you will be able to improve bone quality. MHT is effective for the prevention of osteoporosis in postmenopausal women, but we should not prescribe it solely for this. There should be another indication as well. However, if your patient is not able to tolerate other medical therapy for osteoporosis, she has some adverse events, or other anti-osteoporotic therapy is contraindicated in your patient, or your patient is at extremely high risk of a fracture and she feels, or you feel, or both of you feel that she needs more than one therapy, then you can add MHT. And this is what we have in our national guidelines from India as well, which are quite similar to those from the EMAS. Of course, when we are managing osteoporosis or preventing it, we focus not only on drugs or on MHT, we also talk about lifestyle change. And we try to create an environmental modulation where the environment is friendly for the postmenopausal woman. Now, again, let's come back to this window of opportunity concept. If a lady comes to me with vasomotor symptoms, she's symptomatic, she's in distress. That for me is an indication to treat with MHT, provided there is no contraindication. VMS does have a correlation with osteoporosis because women with moderate and severe vasomotor symptoms have lower bone mineral density and higher risk of fracture. If, therefore, I treat a lady with vasomotor symptoms, I can counsel her that she will get better bone health, better bone density, and she will be able to reduce her risk of fractures, provided that she comes to me within this window of 10 years postmenopausal or less than 60 years of age. We have spoken today about menopause. We are speaking the language of an endocrinologist. But then remember Rabindranath Tagore. He said, keep the petals together, keep the flower together. When we approach a lady with menopause, we should not think like a gynecologist or like an endocrinologist. We should think like a human being. Remember, menopause therapy by the ear. And the first thing you have to do is listen. And I would like to very humbly share this slide with you. Menopause distress. Take time out to listen to your patient and see if she is living in menopause distress. What is this? It is an emotional response. So it is emotion. It is not disease. It is just emotions. You and I, all of us have emotions. It is characterized by a significant and persistent. Note the words significant and persistent. Three emotions that we list here: apprehension, discomfort, or dejection. So this lady is living with apprehension, discomfort, or dejection, which is significant and persistent. And why does she have it? Because of a perceived inability. Again, note the word perceived inability. She herself perceives unable to cope with. So it is a coping disorder. She has a perceived inability to cope with the biomedical and psychosocial demands and challenges of living with menopause. If this lady is in an emotional state where she is afraid, she is uncomfortable, or she is sad, she thinks she cannot manage life with menopause. What is the treatment? The issue is not menopause. The issue is her thinking. She thinks she is not able to manage. Her perception, she perceives that she is not able to manage. What treatment will we offer? We will correct her thinking. We will correct her perception. How will we do that? We will strengthen her. And that is what we should do. If we can understand menopause distress, then all the barriers that we face to menopause hormone therapy will automatically be converted into bridges. Let me share this 5P mnemonic with you. In spite of all the best possible knowledge that we have, there is data to show that nearly 90% of all deserving women with indications for MHT, do not get the right therapy. The barriers to getting this therapy, menopause hormone therapy, might be because of the physician. The physician is not aware. So through EMAS, we are trying to correct that. We are trying to create a bridge between all of us. It might be public. The public feels that postmenopausal health is not important enough. So we should take the lead and we should speak out for women living with menopause. I actually think that postmenopausal women have an equal right to good health and the best possible medication as compared to non-postmenopausal women or to men. Policymakers should understand the role of postmenopausal women in society. And I'm very happy that EMAS is actually leading this advocacy for menopause management in the workplace. P is for patients as well. P for physician, P for public, P for policymakers, P for patient. Sometimes patients are afraid. So we have to correct their misconception. We have to talk to them about what is right and what is wrong. And P is for pharmacology. This is actually sad because there are so many good therapies that we have available now. Topical and oral. In India, we have injectable as well. But we should be able to create clarity in the therapeutic landscape. And I hope that in this series of programs that we have through EMAS, we should be able to convert confusion into clarity. A simple slide to help you. Whenever you think of prescribing MHT, go stepwise. If your patient has an intact uterus, then you would want to give estrogen plus progesterone. If your patient does not have a uterus or a non-functioning uterus, then you can give estrogen alone. You can choose oral drugs or you can choose transdermal. The indications are there. In estrogen plus progesterone basket, you might want to give a sequential therapy or a combined therapy. You might want to give it in pulses, in cycles, or you might want to give continuous. The decision is based upon you and your patient together. Allow me to conclude now with this simple slide. We do speak of menopause therapy, menopause management, but we should also be mindful of something known as quaternary prevention. So we should avoid over-medicalization and over-treatment of menopause. Give what is recommended by the guidelines. Give what is correct. Monitor your patient regularly, carefully, and choose the right therapy for the right patient in the right duration at the right time. Follow this timing hypothesis. Catch that window of opportunity. If you can catch that window of opportunity, just open it. You will find wonderful health awaiting your patient, and you will find great satisfaction awaiting you. All you have to do is think of the lady as one whole, as a beautiful flower, and just provide that holistic delivery, that holistic care to your patient. If we are able to achieve this, we will be able to achieve the best possible care, the best possible health for all women living with and after menopause. Thank you.
Thank you, Professor Kalra, for an amazing presentation. And now we will begin the Q&A session. We invite you to use the Q&A widget located in your control panel to submit your text questions for our speaker and our chair. Professor Hirschberg, the floor is yours.
Thank you so much for a very, very nice overview of menopausal transition, the endocrine changes, the symptoms, and also some medical risks. I'm sorry, I cannot. No, I can.
Yes, thank you.
So I think it was a very, very nice presentation, and especially the holistic view, which we are talking about, which is very important. There are some questions and also comments in the chat. And I think I would first like to hear you comment a little bit about menopausal age in different parts of the world, because we got some response on this. For instance, in China, about 49 years of age. In Mexico, 47 to 48. In Australia, 51. In Nigeria, 50. And in Sweden, where I am coming from, it's about 51 years of age. So I think it seems there could be some differences all over the world. Would you like to comment on this?
Yes, I think things are changing. Just like across the world, puberty is occurring earlier and earlier. Similarly, I think menopause is occurring later and later. And as you have better socioeconomic status, better access to health, better access to nutrition, maybe less pollution, I think the reproductive cycle is increasing. So earlier puberty and later menopause.
Yeah.
I'd like to take the opportunity, Dr. Angelica, to greet Professor Antonia Ogbera. She's from Lagos in Nigeria, and she's logged in with us today. She is the primary author of one of the studies which I presented today. So thank you, Tonia, for being with us.
I also asked the listeners about the use of menopausal hormone therapy, because we all know that this has undergone dramatic changes during the last decades. And for instance, in Sweden, the frequency of use was about 50% in the late 90s. And nowadays it's about 5 to 6%. And I believe that this is very, very different in different parts of the world as well. What about India? Do you have figures on this?
We don't have specific data, but certainly it is less than 5%. The number of deserving women, deserving candidates who get systematic MHT. So we have a lot of work to do. Yes,
I think this really could be very, very different in different countries, but I did see some response from Norway, about 14%, I think it was. So this could really be different. Then we have some specific questions here. I will see if I can find one of these.
Professor Hirschberg, please see the Q&A widget.
Yes, I'm looking at it.
Excellent, thank you so much.
Let me see, I'm soon here. Yes, here's a question from Dr. Mohan Shinoy. And this is MHT use is heterogeneous, generally skepticism, distribution of MHT prescription and acceptance varies according to the practice trends, more evidence is gathering. Yes, this was more a comment, and I think this is true. But here we have a more specific question. Will you consider HRT transdermal estradiol and utrogestan to lady with BMI of 50, poor diabetes control, hyperlipidemia, HT on treatment with Q risk score of 30?
Certainly, it will actually help the patient. So, because see, the parameters are so bad, all the parameters that you are sharing, I'm sure the patient's quality of life will be very poor. When we give estrogen, and transdermal would be a good idea, you will actually find that the patient's quality of life will go up. She will begin wanting to exercise, that much I can promise. So her interest in self-care, her approach towards her own body is going to improve, and you will actually find very good results. Whenever you are prescribing MHT, you can counsel your patient and also make yourself understand it is not a lifelong commitment. Suppose I prescribe MHT today, whether transdermal or oral, it would not make sense for me to stop it after 7 days. I mean, even the effects will not come within 7 days, but we can always give it for a few months. And you should have an endpoint in mind. The endpoint can be, it can be motor symptoms, vasomotor. It can be mood and cognition. Here, what we will focus on is mood and cognition. And if you get that improvement in mood and cognition, you can always reassess risk and benefit after a few months, and then you can stop. So if you have this kind of a communication with your patient, it will actually help both of you.
But do you really think that a couple of months of treatment will have will help her in the long run?
For this particular patient, Dr. Angelica, I think it will help her get up. I'm sure this lady is not in a happy state of affairs, and the MHT will improve her mood, that I'm sure. So it's like, yeah, when you're doing diabetes management, obesity management, the toughest part is motivation. So we spoke of mood and cognition. Another M would be motivation. Let's try and see what happens. There's no harm in giving a therapeutic trial. Of course, you have to be mindful of all the contraindications. So not the metabolic ones, but you know, the gynecologic and the malignant, those kind of contraindications, you have to be mindful of those.
And we all know that physical activity is important during menopausal transition. And what kind of advice would you give to a woman with such high BMI of 50?
She needs to begin moving, but it is difficult. So let us classify exercises into 3, and let us do a hierarchy of exercise prescription. The first to learn is balance and flexibility. So let us begin balancing exercises and flexibility exercises. And we can spend a couple of weeks just doing that. Once you've done that, then you move on to aerobics. Aerobics can be classified into 2, high impact and low impact. This lady should not be advised high impact exercises. High impact means that any point of time, both her feet are off the ground. But she can easily do low impact exercises, which means at any point of time, one foot is off the ground. It doesn't have to be weight bearing as well. She can sit in a chair and she can keep on, you know, like marching on the spot. Like you march on the spot, usually you are standing and marching, but she can do sitting and marching on the spot. Once she is comfortable with that, then you move on to resistance exercises. So we go stepwise in a hierarchy. Resistance exercises, nobody is telling you to wait to carry a 20 kilo dumbbell on day 1. It can even be 1 kg or 2 kg. Let us say you're at home. You do not have a dumbbell. There are so many things in the kitchen. You just carry any utensil or maybe any pumpkin or whatever, the turkey that you want to use for Christmas. So you can practice weightlifting with things that are available at home. Once you explain this to your patient, I think things are good to go. Look for what the patient wants, what she likes. Maybe she liked folk dance when she was younger. So you put that folk dance music and let her dance to that.
Oh, thank you. There are more questions. We will see what we have more here.
It is so nice, Dr. Angelica, to see people from across the globe,
Yes.
all the way from Peru
Yes.
up till East Asia. So
Yes,
greetings to everybody who is logged in.
Wonderful. Here's another question. Can a patient have MHT for osteoporosis? Should bisphosphonates be kept for later after 60 due to side effects? And drug holiday period can be given up to 5 years.
Okay.
What
So
was
when
your
we
comment?
manage osteoporosis, actually MHT will come a bit down the line. Our first choice will be either an anti-resorptive like bisphosphonate or an anabolic drug. Depends upon which country you are in and what is the relative cost of drugs. One of the best drugs that we have is denosumab, but that is expensive in India. Another drug that we have is teriparatide. These are the anabolic drugs. Either we use these, or you cannot use both together, or we use an anti-resorptive drug. Amongst the anti-resorptives, the bisphosphonates, you can use oral every day, oral once a week, or you can use zoledronic acid once a year. These are quite economical, especially in India. You can give sequential therapy. Sequential means for 2 years, I will give anabolic drugs to build up my patient's bone. After that, I will shift to anti-resorptive to prevent further resorption. Whatever I'm doing, if along with this, my patient has got vasomotor symptoms, I can add MHT to that. But MHT will not be a primary therapy for osteoporosis.
But what about women with early menopause? We do not recommend bisphosphonate for younger women.
No, only if they have osteoporosis with a T-score less than 2.5. Then we will use. It is up to you whether you want to choose a bisphosphonate that is anti-resorptive or an anabolic drug. In general, it would be good to give anabolic first for 2 years, followed by bisphosphonate. That would be the general approach, a sequential approach. But this will be done only if the patient has documented osteoporosis, either a T-score less than 2.5 or a fracture. You can see the fracture. So then you do not need to go and do a DEXA also.
But for instance, for hypogonadism in women of fertile age, it is recommended to use estrogen therapy.
I agree. So I understand, Dr. Angelica. So I apologize. So it is just about terminology. If a patient has got premature ovarian insufficiency, then the drug of choice is MHT. Yeah. Yes, that should be a strong take home. If your patient has got premature ovarian insufficiency, then you will keep on giving MHT until the expected age of menopause, which would be 51 years in Sweden and maybe 50 in Nigeria and 47 in Mexico and India.
Here is a similar question. Thank you, Professor Kalra, for such a clear presentation. Am I correct in thinking that MHT is the only treatment of benefit for improving BMD in women who are osteopenic, not have osteoporosis, but are osteopenic?
No, I apologize if you got that message. The best treatment would be anabolic. Example would be teriparatide, followed by bisphosphonates, that is anti-resorptive. And along with that, you can add MHT if there is a need for that, or perhaps if the patient does not tolerate the other anti-osteoporotic therapies. Yeah.
And maybe especially if she also has vasomotor symptoms, right?
Yes, if she has vasomotor symptoms, and I note so many people logging in. Professor Beatrice Ann is logged in from India, and Dr. Mohan Shenoy. If your patient has symptoms, vasomotor symptoms, do not disregard them. View them as a pre-diabetic state. View the symptoms as an anginal equivalent. View the symptoms as a marker for fragility and fracture and fall. Rather, fragility, fall, and fracture. So catch this window of opportunity. And because you're going to give estrogen for the vasomotor symptoms, because they are estrogenic, you can counsel your patient that we will be able to prevent other issues as well. But do not assume that MHT will obviate the need for the patient to go and get a cardiology checkup or get a DEXA or get a glucose tolerance test. That must be done along with the MHT. But you can use MHT without feeling afraid. If you're a gynecologist, do not feel afraid. These drugs will actually help the mood and metabolism and musculoskeletal strength of your patient.
And for an ordinary patient, so to say, who have menopausal symptoms, for how long would you treat her?
This is a very difficult question, varies from patient to patient. So start early, be swift, and come back early also. You usually will begin for symptoms. So maybe for 6 months or a year. Now, if at that point in time, your patient is doing very well and she says, I'm comfortable, my bones are stronger, my muscles are stronger, the patient does have osteoporosis, and now patient is at maybe a T-score of -2.6. If you take off the MHT, right, you might find that the bones will become weaker. So what will we do? If your patient is doing well, let's say you're driving maybe in Germany and you're driving at 120 kilometers per hour, everything is fine. Will you change the gear of your car? The answer is no, you will not change. You will keep on driving the same way. So you continue the anti-osteoporotic therapy, you continue the MHT, but you cannot give MHT indefinitely. So the maximum would be till age 60 or till 10 years of menopause. And many people suggest less than that.
Have you experienced patients who do not want to stop?
Yes, so many, especially in North India, especially educated ladies and ladies who are in the in social service, in the public limelight. They just do not want to stop.
What do you tell them?
I go for shared decision making. I refer to a gynecologist and I say, maybe the two of us, we've been working as a team so far. Let's take a third opinion. Let's take an opinion for somebody else. Now, I will not worry about metabolic issues in this lady. The lady is 65 years old. She's doing a great job. But I'm not, as an endocrinologist, I'm not confident about what is going on inside the uterus, inside the breast. So if a women's health professional tells me that things are fine, then I'm comfortable continuing.
Let me see, we have more questions. Maybe we have time for some more. Thank you for your lecture. How do you define the need of MHT for patients with not heavy hot flashes? For example, will you prescribe MHT for a woman with 1 hot flash per day, or 5 hot flashes per day, or 20, or how many?
We ask the lady, if it is significant, then we prescribe. So it depends upon the patient. And let us say the hot flashes are not too much. You can teach other things also, cognitive behavioral therapy. You ask the patient to keep a diary. When is it that you experience a hot flash? This is something known as, it comes from management. It is known as Ishihara's chart or a fishbone analysis. Fishbone means that you keep on going back and back. Okay, you got a flash 10 times last week. Why don't you show me a diary? Out of these 10 flashes, 7 occurred at 9 a.m. or at 9:15 a.m. What were you doing? I was getting ready to go to work and I was stressed. I may be late, and if I get late, I will not be able to do the biometric attendance. I will lose my my salary for the day. So why don't we get a 15 minutes earlier and let's see what happens. Another example of a hot flash precipitate like this in women would be when I take a cold shower, I'm comfortable. But if I take a hot shower, then the moment I come out of the bathroom, I get a hot flash. Okay, so what do? You just reduce the temperature of the water. So these kind of things can also help.
For sure. We also ask how much the symptoms affect life quality.
Quality of life.
I think that's very, very important. Let me see if we have time for maybe some more question.
It is so nice to see people from Russia, Ukraine,
Yes,
Peru,
yes, yes.
India, Nigeria. It is so
there are
beautiful
so
interacting with all of you.
Here's another one about metformin. Do you use metformin in therapy or metabolic syndrome during MHT? I mean, the combination, and for how long time?
No, metformin will be prescribed only if the patient has diabetes or if the patient has pre-diabetes with multiple other risk factors like obesity, dyslipidemia, smoking, a strong family history of diabetes. So otherwise, we will not prescribe metformin as a routine therapy, only for diabetes and select patients of pre-diabetes with high risk factors.
We have many more questions here. I think those of you who are able to stay a little bit longer, is it okay that we take some more questions for you?
Oh, yes, certainly. And greetings to everybody from Armenia, from China. It is such a good feeling being with everybody. And Dr. Angelica, honestly, it's a good feeling being with you as well.
Thank you, the same to you. Here's another question. What about use androgen hormones in management of muscular weakness in menopause?
They were used a lot earlier. And I have used a lot of androgen about 20 years ago in my practice. In India, we had and we continue to have injectable therapy with the estrogen and very small doses of androgen. I do not use it very often now, maybe once or twice a year. Actually, the cost is also it's so economical. It's just about $100, maybe $1.50 for an injection. Now, in which patients will I use androgen, small doses? Let me just describe the picture for you, right? The injection that I have available is androgen, testosterone plus estrogen. There is no progesterone in it. So if my patient does not have an intact uterus, I can consider giving this injection.
Did you say it was a combination of testosterone and estrogen? And
estrogen, yes, okay. That is what we have available in India. But there is no progesterone in it. So if my patient does not have an intact uterus, I can consider giving this injection. The beauty of this injection for me is that it is so economical. Patient will come in and take maybe once a month or even once in 3 months. What is the advantage? The hot flashes will come down, libido will go up, mood will improve. So if my patient has come to me with a predominant complaint of loss of libido, and that is impacting her marital harmony, then I will consider this. Now, the only issue is that it is younger women who come with this complaint more often. Somebody with premature ovarian insufficiency, or somebody who unfortunately had a total abdominal hysterectomy done for whatever reason. If I begin giving this therapy to a 32 or 35-year-old lady, she is not going to stop. She will continue for the next 10 years. And then there is a real risk. I have seen in my clinic, there is a real risk of hyperandrogenism. So this is something you have to be careful about. But again, let me repeat, I do use this injection every now and then. If the chief complaint of my patient is loss of libido leading to marital disharmony, and she does not have an intact uterus.
I mean, the availability of testosterone for use in women differs in different parts of the world. And for instance, in Europe, we do not have any preparation treatment in women. So we usually use a gel.
Yes.
But with this injection, do you know what testosterone level you will reach, the highest level you will reach with this?
It is just 50 milligrams. So it is even, the dose is half of what we would use for induction of puberty in boys. So it's a very low dose. But from an international perspective, let me just describe, if you want to use, how you'll use. Either you can use an injectable testosterone, the one that is used for men, but the dose will be very high. So that is contraindicated. You can use a capsule, a 40 milligram capsule of testosterone undecanoate. In most men, we require 3 or 4 capsules a day. In women, you might want to use 1 capsule a day, even 1 capsule every other day. The gel is the safest. Men will take 5 grams every day. That is the standard protocol. In women, you might want to give just half a sachet every second day. But you have to talk with your patient very carefully. And I personally cannot think of any other indication right now except for loss of libido.
No, it should be the only indication.
Yeah.
Yes.
If you're using it, because I see so many questions coming in, there's a lot of interest. I would suggest that first of all, you document the discussion on your notes that you have discussed with your patient. And you also talk about the red flags. Supposing the patient begins noticing hirsutism, she should stop immediately. And then it will vary from lady to lady. Some lady might say, I don't mind a little bit of hirsutism as long as I'm comfortable with my husband. And another lady would say, this is an unacceptable risk for me. So, but document whatever is written.
I think we have time for maybe 2 more questions.
Yes.
So this is one. If a 25 years old woman have cured leukemia by radiotherapy, which therapeutic schedule will you choose to relieve her climacteric symptom?
We would, and does she have an intact uterus? I think you have to answer that question. Otherwise, if the patient does have an intact uterus, even after chemo or after radiotherapy, then it will be estrogen plus progesterone. I would give a cyclic regimen. And because she's so young, she should have periods regularly. If, however, there is no uterus, then continuous estrogen will be fine. You can use oral or transdermal. Cost is also an issue. In India, for example, we have transdermal gels, but they are very, very expensive. They are, I think, about maybe 10 times or 15 times more expensive than the oral therapy. So we prefer more of oral drugs here because of the cost. Yeah.
Otherwise, in Europe, we see the development to use more transdermal estrogen nowadays.
Agreed. Yeah, the same is true for andropause or hypogonadism in men. Gradually, the world is shifting towards more of transdermal gels. But then it is a cost which will play a major role in many countries, like in Peru, for example, or Nigeria, or even Armenia or
India. I think we choose the last question now. And I think this question is about women when MHT is contraindicated. For instance, women having breast cancer. Thank you, Dr. Kalra. Which is the best SSRI or SNRI to be used in peri-postmenopausal women?
We have a wide choice. My favorite is paroxetine. And let me tell you why, self-disclosure, because my mother likes it. She's 80 years old. So paroxetine is my favorite. Another drug which I use frequently in my OPD is sertraline. So these are the 2 drugs which I use more often. I would suggest that you choose any one drug which is available to you, which is fairly economical. You have a choice between duloxetine, sertraline, and paroxetine. Duloxetine will usually come as a capsule, so you cannot break it. Sertraline will usually come as a squad tablet, so you can, give half a tablet also if you want. Counsel your patient about the chance of increased sedation. Start with the lowest dose and tell the patient it's a long journey, it's a marathon. So do not increase doses every day. Let's just give it a week. Also talk about cognitive behavioral therapy, keeping a diary, things like that. Redistributing the burden of life. Let us say the lady is a housewife as well, and she's a working lady. She's handling so many things. If she knows that most of her symptoms will come in at maybe 9 a.m. or 9 p.m., let the family get together and reduce the burden on her at that particular time. Let the children ask for breakfast earlier or maybe later. Things like that, small things that you can do for the lady with menopause, and things should be fine. If you want to use amitriptyline, that is another drug which is used, be aware that that will cause more sedation. It can cause constipation. It can cause urinary retention. So beware of these. Venlafaxine is something that I do not use because then you have to do a little bit of cardiac monitoring. And I'm afraid of that. So my favorite drugs are paroxetine and sertraline.
Because regarding effectiveness, there is no difference really between the different SSRIs or
yeah, Dr. Angelica, you would also have noticed it's more about how you, in India we call this VAT, value added therapy. So across the world you have value added tax, VAT. This is value added therapy is a nice thing. You prescribe the therapy, but the value is in how you are speaking to your patient and how you are listening to your patient. That is value. That will decide whether the drug is going to be effective or not.
I certainly agree with you. So I think we have to stop now.
One question for you, ma'am, from my side. I was just waiting.
Okay. Okay.
It's been so many years now. If you could share with all of us, over the past, let us say 1.5 decades, how has your confidence in menopausal hormone therapy changed? Are you more confident now when you prescribe a good estrogen with maybe dydrogesterone? Are you more confident than you were 10 years ago?
I think this is a very, very good question, because even if we have used MHT for many, many decades, since the 1950s, there are still some questions we do not have the answers for, because I mean, that is not controversial that estrogen is extremely efficient for treatment of menopausal symptoms. But regarding the complicated, the potential risks, we do not still have all the answers, because we know that treatment duration is important, the specific drug you are using, the combination of the estrogen or progestin component, transdermal, oral, and so on, and how BMI could interact in the risks, for instance, of breast cancer and so on. But the most important is that the change has moved from more preventive treatment for the whole life in the late 90s. And today we talk about treatment for symptoms. And for treatment of symptoms during a couple of years, I think for most women, this is certainly beneficial. So I both feel more confident, but still we don't have all answers yet. I would like to thank you, Professor Kalra, for a very, very nice overview of the menopause transition, and considering all the comments and questions we have received, I'm sure that this was very appreciated by all the listeners. And I would also like to thank all of you who have sent your comments and appreciation and questions. But now it's time to end this, and I hope to see you in the future. Okay, thank you so much, everyone.
Thank you.
Bye-bye.
Best wishes for a happy and a healthy future to everybody.
All right, this concludes the webinar. Thank you so much, Professor Kalra and Professor Hirschberg, for an amazing event. And thank you to all the attendees for being here today. Have a great rest of the day.
Thank you.